Thank you for joining us this evening. My name is Doreen Heineman, and I'm the program manager here at Sashbear. The Sashbear Foundation is a Canadian charity recognized nationally and internationally as a leading voice for families impacted by emotion dysregulation, suicidality, and related mental health challenges. You may know us for the Family Connections program, which we provide across Canada, but also for these expert education series presentations and for our annual Sashbear Awareness Walk and our many other activities, raising awareness and providing skills and hope for families. You can go to our website and follow us on social media to learn more about all of these different activities. Now, as I mentioned, Sashbear is a registered Canadian charity, and as a charity, we depend on donations for much of the funding to do our work. Therefore, we ask that if you are able to support us, you make a donation to help us with what we do. So with all of that said, thank you once again for joining us. And I would now like to introduce our presenters for this evening. So Bob Drozek is a staff psychotherapist in the Personality Disorders Service and Division of Alcohol, Drugs, and Addiction at McLean Hospital in Boston. He serves as a supervisor in the Mentalization-Based treatment clinic at McLean Hospital. He is a teaching associate in the Department of Psychiatry at Harvard Medical School, and also an MBT trainer and supervisor through the Anna Freud Center in London. And Brandon Unruh is an instructor in psychiatry at Harvard Medical School, and he is the medical director of the Gunderson Residence of McLean Hospital, which is a specialized residential program for individuals with severe personality disorders. He is also the founding director of McLean's outpatient mentalization-based treatment clinic for personality disorders. And his clinical approach is anchored in the integration of various evidence-based treatments for personality disorders, including dialectical behavior therapy, mentalization-based treatment, transference-focused psychotherapy, and general psychiatric management. He is also an MBT trainer and supervisor through the Anna Freud Center in London. And Brandon and Bob together are co-authors of a recent book called Mentalization-Based Treatment for Pathological Narcissism, a practical guide, published in 2023 by Oxford University Press. And I want to remind you that in December, these same presenters were with us and spoke specifically about narcissistic personality disorders. So if that is an area of interest for you, please check out that presentation, which is also posted on our YouTube channel. So I will now turn it over to you, Brandon and Bob. Thank you so very much for being with us tonight, and we look forward to hearing what you have to say about mentalization.
All right. Well, thank you, Doreen, and everyone, Barb, Trisha, and just Sashbear more generally. We really enjoyed being here back in December and getting to know you, but just really especially given that we spend so much of our everyday lives sort of helping folks with borderline personality disorder and other personality disorders. Just really grateful for your service in this domain in terms of, supporting patients, supporting the people who support patients, family members. So it just sort of makes our work sort of more effective. And we're just grateful for your service in that regard in Canada. So I will share my screen. Let's see. Okay, can people see that? Does it look okay?
That's perfect.
All right, good. All right, so our talk today is going to be about mentalization, utilizing reflection to heal from borderline personality disorder. So just to give you a little bit of background, some of this has already been shared about us. Brandon and I are both staff and directors in the MBT clinic at McLean Hospital. We train other clinicians in MBT through the Anna Freud Center in London and also the Gunderson Personality Disorders Institute. And I guess it's already been mentioned, we partnered with Anthony Bateman, who's one of the developers of MBT, the lead developer of MBT, to just publish a recent book on MBT for narcissism. And it's relevant, that point is relevant because a lot of the ideas we're going to be talking about today kind of come out of our particular kind of take on MBT, kind of where we really try to distill MBT to its core elements, for the purpose of training, but also, helping folks understand what's really the heart of this evidence-based therapy. So this is the book. Anthony helped us write it. And yeah, so an outline for today. We're going to start. I'll talk a little bit about what mentalizing is, and a little bit about MBT and how it was developed. Brandon's going to review MBT's theory of BPD. Then talk a little bit about the structure, aims, and techniques of mentalization-based treatment, to kind of get our hands around what it is and what it means to, what it would look like to be a patient in MBT. And then I'll come back in and review some therapeutic techniques that might be relevant for patients and families. So let's start with mentalizing. A very reasonable kind of first question is, what is it? And, sort of it can be defined in different ways, but really it's the ability to read, access, and reflect on mental states in ourselves as well as other people. So it's an imaginative capacity, and really what they mean by imaginative is that obviously we can't see mental states, right? We see movements, we see faces, we see bodies, we see actions, but mentalization is really where we're kind of filling in like what's going on inside of the people that we're interacting with and what's going on inside of ourselves. So really mental states can really run the gamut. Thoughts, beliefs, emotions, desires, needs, attitudes, values, feelings about ourselves, personality traits, or all the invisible stuff of the mind. And it is a two-pronged capacity in that we are sort of thinking about it. We can do it with ourselves. We can look at other people try to mentalize. So, at any given moment, it can sort of be directed inward versus outward. And also it's something that, can be deliberate or reflexive, in terms of just naturally when we're interacting with each other, we're mentalizing. We're kind of like trying to understand and read what's going on with the person that we're interacting with, but also we are able to kind of slow it down a little bit and actually try to sort it out. Okay, so-and-so seemed a little bit different in that interaction. Can I wonder what was going on for them, right? So it's happening all the time in the background, but also we can sort of make sure that it happens in the foreground, which is something that we're doing in the treatment. So in just more experienced near ways, there's kind of a bunch of different ways to kind of spell out what mentalizing is. Attending to mental states, holding mind in mind. I really like this one, to make mental, to mentalize. It sort of highlights the agency and sort of the activity of mentalizing. Thinking about thinking, and also understanding misunderstanding, and then seeing others from the inside and ourselves from the outside. So lots of different ways of trying to kind of put our hands around the same construct. So in the book, we've kind of spelled it out, even a little more in terms of what are the different domains of mentalizing, or you might even just see it as different types of mentalizing we can do. So we're proposed that that mentalizing can happen across 3 different domains. One, the most foundational of those, is what we call content mentalizing. That's where we're really thinking about what we and other people are thinking and feeling, and then that might be something like, wow, just the question, like what's going on for so-and-so? What are they experiencing? Also, though, it could be, I think so-and-so is sad, I think they might be a little bit anxious. That's an example of content mentalizing. We can also happen in a maybe more advanced way. And there can be what we call context mentalizing. That's thinking a little bit about the why, not just is so-and-so sad, but like what's been going on in their life recently that could be affecting how they're feeling. That question is a context mentalizing question. And that's where we look at the relationship between mental states and other things. It could be situations, could be there other people's behaviors, could be other parts of the mind that could be affecting. Like, oh man, the person may be a little sad. Like, what could that be about? And they also might be a little lonely, right? So we can kind of expand the picture a little bit. That's context mentalizing. And also process mentalizing is really where we consider how we relate to mental states in ourselves and other people. And that really involves the best case scenario, some level of flexibility, tentativeness, humility, where we're kind of no, since we can't see mental states, there's, in some ways we're called upon to be humble about them, what we can ever know about them, because they're not visible. We also can focus on, we're focusing on psychological rather than strictly visible factors. Another sort of process-based point is it's not just about saying like, I think I'm sad. It's like actually being able to feel the sadness. Like once it's been identified, actually being able to access the thing. That's a part of good mentalizing. And similarly, you can read another person, but not necessarily always care what you're reading, care about what you're reading, So I recognize that so-and-so is sad, but am I really resonating with it? Am I really moved by it? So good mentalizing is not just about putting words on what others are feeling. It's also about caring about it and being moved by it when that's needed the most. So it's a different facets of mentalizing that we think about in MBT, and genuine curiosity and interest in mental states. So just to give a little bit of the history of MBT, the current view of mentalization was proposed first by Peter Fonagy in 1989, and really like seminal psychoanalytic paper. He's a Hungarian-born British psychoanalyst and clinical psychologist. So he really introduced it. And then collaborated with Anthony Bateman, who's a psychiatrist, also a psychoanalyst, from England, to develop and empirically validate MBT. And basically Anthony was in charge of both Peter and Anthony were sort of recognized that traditional psychoanalysis, which was really the kind of mainstream form of psychotherapy being provided in England at the time, really had limitations when we thought about patients with borderline personality disorder or severe personality pathology. That traditional psychoanalysis didn't seem to work very well to help these, folks improve in their lives. So Anthony was sort of the director of the Halliwick Day Hospital program in London. And he was really tasked. They had tons of patients, lots of different patients that they were supposed to treat. But the system was, there was more demand than there was actually availability to kind of help these folks. So he was really tasked with coming up with a method that hopefully sort of grounded in some level of theory or science that would be able to help these folks. And so at that point, Anthony was familiar with Peter's work, and they started communicating and really started, kind of spelling out the principles of mentalization-based treatment, which Brandon's going to be talking about. And basically, they ended up researching MBT, this sort of model that they developed, this is in the 90s, and found in the first paper on MBT in 1999, that over the course of 18 months of treatment, while patients receiving treatment as usual showed minimal improvements, patients receiving MBT had significant reductions in a bunch of really important areas that aren't always very movable or weren't always very movable in the sort of traditional psychotherapy of the day. So improvements in self-injurious behavior, suicidal actions, fewer inpatient hospitalizations, decreased medication usage, improved depression, and then broader improvements in interpersonal functioning. And those gains were maintained at 18 months post-treatment, and then follow-up studies have shown they've even been maintained 8 years after the conclusion of MBT. So my sense, Brandon, you can correct me if I'm wrong, is that those are some of the longest follow-up studies in the treatment of folks with borderline personality disorder, to show that this sort of dose of 18 months of treatment, that we can have these significant gains, they can be maintained. It's really, really pretty significant, empirical support. So this was later replicated for outpatient MBT, both by Peter and Anthony, but also other folks who've done randomized controlled trials. And they really started training people in MBT through the Anna Freud Center. I think this was done in the 2000s to 2010. They started coming over and sort of doing maybe like smaller trainings. And really just sort of, doing the boots on the ground work to be able to help people learn more about the therapy and learn how to do it. Ultimately, both Peter and Anthony were close with John Gunderson at McLean Hospital. And really, there was a period where they would be coming over and helping to kind of infuse the principles of MBT into a lot of McLean's programs. So Brandon is the medical director at the Gunderson residence, and really at the early phases of that that program, helping to, Peter and Anthony really helping to kind of think through how to build the principles of MBT into the treatment that was being provided there. And then ultimately, Brandon worked with Peter and Anthony to develop MBT's training clinic, which is the only adherent MBT clinic in the United States where we're providing solely insurance-based care. Lois Choi Kane, some of you might know Lois, helped to develop the Gunderson Personality Disorders Institute, which is really devoted to the dissemination of training about evidence-based therapies, including MBT. And at this point, MBT is now a first-line treatment for people with BPD, and there's emerging evidence supporting its efficacy for antisocial and for adolescents with self-injurious behavior. It's really kind of broadened in lots of different ways. There's research showing utility in MBT in treating depression, trauma and PTSD, substance use disorder, eating disorders, mothers with addiction, psychotic disorders. And also, even sort of social and cultural problems like law enforcement violence. There's not research on this, but it's an application of MBT, I should specify. Law enforcement violence, children in foster care, parents undergoing divorce, school bullying, and family members of people with BPD too, which we'll talk about a little bit later. So that's where MBT is at right now. And I'm going to turn it over to Brandon to talk a little bit about how MBT understands borderline personality disorder.
All right. Is everybody able to see my screen, hopefully? Bob, is that looking good? All right, very good. Well, just briefly again, good evening, everybody. It's so nice to be with you and to be back. It's nice to be able to say, and thank you again, Sashbear. I mean, we just recognize what a pillar of support you are for our patients, for us as clinicians, and for loved ones and family members in particular. So thank you for all that you do. So as Bob said, I'll just talk for a few minutes about the basic theory of how do we understand the problems of borderline personality disorder through this mentalizing lens. So we start with kind of just the recognition that people with borderline personality disorder very often mentalize quite well. And like for most of us, that capacity to read and access and reflect on mental states, as Bob described, when that's reasonably intact, that helps people with BPD deal fairly well with the slings and arrows of life, the disappointments in relationships, one's own sense of personal failure, sort of all the things that we all have to contend with. But in BPD, we think that there are these particular context-dependent vulnerabilities in mentalizing, which get triggered in, we just think sort of for simplicity's sake, in two types of circumstances that we can think about and recognize as clinicians. First of all, when there's some kind of interpersonal risk or threat. And when we say this to patients, people immediately think rejection, breakup, feeling criticized, being abandoned. But we also want to think about increasing intimacy and closeness and how that becomes quite interpersonally threatening for people with BPD as well. That certainly activates some of those fears of rejection and criticism and abandonment. So it's on the side of closeness and distance within interpersonal relationships. And then any intensity of emotion is a threat to good mentalizing. So if I'm really angry with a friend, I'm not likely to be imagining the most charitable explanation of why they did the thing that made me angry. Or if I'm deeply ashamed about myself, I'm not going to be generating balanced views of myself, reflecting on what feels wrong or bad alongside more positive views of myself. I'm going to lose that balance and nuance, and it might just land on a sense that I just am bad. So under these conditions, a person with BPD finds it more challenging to hold on to their minds. And they fall into these patterns of non-mentalizing or hypo-mentalizing experience. So there's this loss of nuance and curiosity, balance, and connections to the self or parts of what might be going on inside. There's connections also to the experiences of others around them get lost. And a person starts to experience themselves or others or the world in general in some way that's intolerable. It might be that they become terrified or infuriated or totally shame-ridden or terribly alone. And this leads to the challenges in functioning and the symptoms associated with BPD, such as impulsivity, self-harm, suicidality, interpersonal problems. Because in these kind of hypo or non-mentalizing mindsets, there's no easy way to recover that apparatus of mentalizing, which helps us all manage these otherwise intolerable aspects of our experience. So here's what's called the tripartite model of borderline personality disorder. And the idea here is that BPD is characterized by attachment insecurity. And what we mean there is a sensitive attachment system that entails all the difficulties around regulating oneself emotionally and behaviorally within interpersonal contexts. And all of that we think is fairly constitutional of BPD from this attachment mentalizing perspective. And what happens is the attachment system becomes triggered, and we say hyperactivated, which itself then activates these problems in mentalizing, which lead then to the symptoms and the functional challenges that we observe in BPD. So as Bob laid out, we have this sort of three-part way in which we can approach and categorize the different problems in mentalizing. So it follows the content, context, process model. So let's just think about content-related problems first. And this is, as Bob said, kind of the what that's in the mind, either my own or someone else's. So when people with BPD are emotionally or interpersonally triggered, there's this struggle to reflect on what's in the mind. What are the mental states within myself or others? And this shows itself in many different ways. There can be just confusion about what myself or someone else is experiencing. So it's to say that the kind of granularity of internal experience gets lost or becomes overwhelming so that it can't be stably identified or held in mind in a balanced way. There's difficulty identifying and putting words on feelings. Sometimes this is called alexithymia. And this is, people sort of end up having to say about their emotional experiencing, it's just empty, it's flat, or it's dead, or I feel nothing. There's difficulty actually expressing what might be going on at a more complex level inside. Sometimes people end up just drawing inaccurate conclusions about what's going on for themselves and others. There's just a getting it wrong about oneself and others. And there's a tendency to miss or to ignore particular mental states in self and others. So an example might be someone who very strongly senses someone's frustration with them, but misses the love and care that is also there. Or someone who strongly senses their own anger towards others, but misses that there's also a longing to connect that is still present at the same time. So you get a sense of these content-related problems. Then if we talk about context-related mentalizing problems in BPD, Well, here we're talking about how when there's that emotional and interpersonal triggering of the attachment system, there's a struggle to reflect on the broader context of what's going on in a mind. And this shows up potentially as feeling confused about why I'm feeling a particular way or why someone else is feeling the way that they are or thinking about me the way that they do. Or there's no clear sense of how I got to where I am or how someone else got to where they got. There's a difficulty with identifying what factors around me situationally in my circumstances or someone else's circumstances might have influenced how they're thinking or feeling or how I'm thinking or feeling. So for example, how might my partner's behavior last night or my own behavior last night, how might that relate to why I'm feeling ashamed today in this moment? There's also trouble recognizing other psychological processes that may be impacting mental states. So if I'm at a party and very socially anxious, I might fail to imagine that a person I just met at the party who won't look me in the eyes or acknowledge me, that person might themselves be quite anxious. They're sort of failing to recognize a process in another person's mind. And then there's challenges around understanding just a general connection between mental states and behaviors. So struggling to understand, for example, what feelings in particular led to an instance of self-harm, or how a friend not showing up at my birthday party might have led to certain painful feelings in the aftermath. There's also a tendency to overly focus on discrete behavior and to miss patterns that might be going on in relationships. So sometimes this is kind of a tragic tendency to see oneself sometimes as I'm just the behavior that I do, and missing a sense of what am I like as a person over time. And there are problems in recognizing what we call as clinicians sometimes intent versus impact. So there can be problems with recognizing how a person themselves is the context of other people's experience, which is to say they're not recognizing the effect or the impact that their own feelings or thoughts or behaviors have on other people, on other people's mental states. And so this is that difference between impact and intent, which is so important in working with BPD. So you can see that these context-related problems in mentalizing are difficulties with taking up a small picture that's already been painted of what's going on in a mind, and then expanding that frame around that picture to include a variety of other relevant factors. So then we get to this third layer of mentalizing, in some ways kind of the most challenging or higher level, so to speak. And this is about process. And when people with BPD become emotionally and relationally hyperactivated, there are these process-related problems in mentalizing. And what I want you all to think about around these process level problems is that the problem is it's not what is being thought or felt. It's how that experience is being held in the mind. And Anthony and Peter say sometimes it's the force or the extent of the thought or the feeling. It's not so much the feeling or the thought itself. So MBT will organize these process-related problems under these three non-mentalizing modes, which we all have, by the way. We all fall into this. These are not unique to BPD, but they're particularly pronounced, pervasive, and frequent, and difficult to get out of in the setting of BPD. So there's some fun jargon here for those of you who appreciate fun and sort of esoteric words. We're not going to sort of drive that home tonight, but psychic equivalence mode is about too much certainty and rigidity around a certain mental state. This is the notion of if I think it or feel it, that makes it true. And this is sometimes called inside-out mode, where the force or the intensity of a particular thought or feeling inside my mind, that makes me certain that something is really and completely true outside my mind. So it's not just a passing subjective experience, it's the reality of the situation. Teleological mode is where there's too much concreteness, or too much externalization. And this is sometimes called outside-in mode, so kind of the inverse of psychic equivalence. And this is when what I observe in the physical world on the surfaces of myself and others, that tells me exactly what's going on inside myself and others. Pretend mode is the third of these, and that's where there's too much disconnection, sometimes dissociation at an extreme level. And sometimes we say this is the head becomes disconnected from the heart. And there are various other kinds of disconnections within the self and between the self and others that are possible. So let's just take each of these a little bit more detail, just quickly about each of these. So when we're in this too rigid and too certain mode, there are these rigid thinking and beliefs that emerge about the self and others. So this could be the sense that just, I am bad, I am unlovable. Or someone said to me just the other day that she believed that she was made to suffer. That's why she was born. You know, these terribly painful beliefs about the self and about others. And those are usually affiliated with powerful, intolerable emotions, debilitating sadness, fury, rage, shame, and so on and so forth. And these mind states are felt to be overwhelming or too real. And you know, there are connections to trauma and PTSD here as well, such as when certain experiences in the mind are held to be actually reliving of the past, such as in flashbacks and re-experiencing. If we look at teleological mode, these overly concrete and externalizing experiences, we see that there's that significant focus on the visible or measurable aspects of experience, or in circumstances, or my own actions, or somebody else's actions, or my appearance, or someone else's nonverbal behaviors. And there's a tendency to allow those visible factors to totally determine what I make about those mental states, what's going on inside, what's behind the action. So this is like where if my worth as a person is determined completely by how many friends I have, how many Instagram followers I have, or by my grade point average, or by the fact that when I got on the bus today, nobody looked at me. Nobody talked to me. Everybody was looking down when I walked all the way to the back. And that tells me that nobody cares about me in the world, that sort of thing. Sometimes people with BPD are driven to act teleologically, and that's this need to engage in specific, tangible, concrete, measurable behaviors, such as reassurance seeking, or aggressive behavior, or self-harm. And you know, this is essentially when someone might be trying to change something on the inside by changing something on the outside, such as by getting someone to reassure me that they like me, or by doing something that causes someone else to feel so badly so that they have a sense of how badly I'm feeling. And this is not generally intentional or conscious by definition. This also goes to how we interpret what's in other people's minds, as I've already said. So a friend who didn't reply to my text message, their non-reply, that tells me actually they were never really my friend in the first place. Or, you know, my therapist looked at the clock just 10 minutes into the session, and that tells me they don't care about me, or they're already thinking about their next patient. So the third of these is too much disconnection. And this is not just not being able to know what's going on inside, or not knowing what one is feeling at the moment, but it's often the loss of motivation to explore and find out. So it's a lack of interest or curiosity in mental states. And in extreme forms, this is dissociation, a total detachment from what's going on the inside of self and others. Sometimes this is intellectualization. So someone may be kind of soliloquizing or monologuing at great length. It's over-rationalization, you know, rational mind in DBT at the expense of any awareness of emotion. Sometimes this is a disconnect between what's going on the inside and important facts about reality, such as the fact that I'm going broke right now, but all I'm talking about in therapy is, you know, something that happened 10 years ago. And that's all I'm focusing on, but I'm sort of not connected with the fact that I'm about to lose my housing, for example. And sometimes it's also disconnected along empathic channels, you know, just not caring about sufficiently what's going on for other people. So these MBT posits then that these non-mentalizing modes then generate the problem behaviors and symptoms that we see in BPD, and that this is happening through an effort to restore self-coherence. And I won't go too much into depth. For those who are interested, you know, we call this sometimes the alien self experience. And this is essentially the experience of this painful, intolerable incoherence and incongruity within the sense of self. And the problem behaviors that we see in BPD, these are understood as functioning to restore a sense of balance and coherence and stability within the sense of self. And there's a relief that goes along with that, often a sense of clarity and simplicity that allows mentalizing to actually come back online. So the problems become the solutions, very parallel to how DBT thinks about target behaviors. So for time's sake, just to I'll give you a little bit of a sense of the treatment. The primary aim in MBT is to strengthen our patients' resilience of mentalizing, to reflect on a problem or during a problem when it's happening rather than respond reactively. And MBT focuses on the areas of experience where our patients are struggling with functional problems, working with them to start, resume, and continue mentalizing. So to first start by getting interested and curious, what's going on inside a mind, and then to resume actually that process of reflecting once they fall out of that mentalizing stance, and then to keep continuing reflecting on mental states when the rubber hits the road and there's a lot of intensity of emotion or interpersonal stress in the moment. And the idea here is that as patients learn in the treatment to hold on to their minds better during these moments of hyperactivated emotion and attachment, but then they become less likely to engage in the problem behaviors over time. So we think that the benefits are an increased sense of connection to their own experience, greater sense of coherence, a greater ability to consider and empathize with the experiences of others, and enhanced agency. So here you see it kind of quickly represented that we think that we are stabilizing that hypersensitive attachment system and those problem behaviors through restoring the capacity to mentalize and strengthening that against the triggers that are so common in BPD. Here's a quick list of things that MBT does not do deliberately. We're not trying to just persuade people to think differently about themselves. We're trying to actually stabilize the capacity to try on different perspectives for size. We're not trying to directly modify behavior. This doesn't mean that we don't sometimes make behavioral suggestions. I'll just say that DBT and MBT elements can often be very usefully integrated and synergized together. We often do that. A lot of clinicians do. But we're not directly aiming at teaching behavioral skills, because the principle is if there isn't mentalizing happening, then a list of skills is just a list of skills, or a crisis plan is just a crisis plan, but there isn't enough reflection to actually implement it in a meaningful way. We're also not trying to generate insight, particularly about one's past or how one's problems came to be. So these are things that might be helpful for people when mentalizing is online, but because mentalizing is so vulnerable in BPD, it's not the aim. So our stance then is that we focus deliberately on mental states. We try to be quite humble as best we can and not knowing about what we can know. And, it's not that we pretend to be stupid or not knowing about anything. We don't just throw our professional training out the window, but the patient is the expert on what's going on for them in the moment. So we need their expertise, and we kind of put ourselves in a kind of person down position because they're the expert in actually trying to explore their own minds. We're here to help facilitate that. We do engage them and structure the sessions quite actively. So we do some agenda setting. It's not free association. We don't just start with prolonged silence. We do things to help get this process going early on in every session and throughout the treatment. And we try to be really excited about differences in perspectives. So we get super active and interested when there's a disagreement or a misunderstanding. These things that just happen all the time in working with BPD. We get interested in, let's slow this down a little bit. Show me how you got to where you got, and let's think about how you're getting somewhere really differently than I'm getting. Can we have a think about those two processes in you and in me? What's different? What's similar? Can we get interested in marveling at that and exploring that together? So we try to own our own mistakes because we make lots of them. We fail to understand ourselves and each other. And we're trying to model that kind of ordinary approach, that humble approach to the mind. The structure has many different components to it. You know, it starts with just assessment and then actually sharing the diagnosis. We're very direct about that. We provide psychoeducation about these mentalizing problems and difficulties. We have a set of treatment priorities and goals. We do crisis and safety planning, like all the other treatments do. We give the patient a written formulation about where we see their difficulties showing up and where they're likely to show up in the treatment, and then we actually begin the treatment. I'm going to skip past kind of the specifics about technique here to pass it over back to Bob. But just you see here that we follow this content, context, process focused stratification. And I'll leave Bob to pick it up there.
All right, thanks, Brandon. Let's see. Yeah, let's think a little bit about what it looks like to put this into practice. And I definitely see in the chat, people are asking this question, like, how does this sort of differ from DBT, and sort of what are similarities, what are areas of difference? So hopefully we can talk about that more in the discussion section, but we'll try to get a little practical now if we can. One thing we thought it was important to review was just that, sort of, because there has been a randomized controlled trial on MBT for family members of people with BPD. So it's MBT Facts, it's called. So yeah, it's for family members or significant others living with or supporting a person with BPD. So it's kind of cool. The family members helped to write the manual and deliver the intervention in the study. And the program covers 5 topic areas: education about BPD, mindfulness, and mentalizing. There's similarities, but they also can be different. We can talk about that a little bit. And then use mentalizing role plays to address problems in the family. Talking about how to empathically validate, which is an essential part of MBT. And then problem solving of, like, sort of what are challenges people could experience, and a broad review of the main kind of content areas. So yeah, so the randomized controlled trial compared the efficacy of an immediate treatment group, maximum 5 weeks wait, to a delayed treatment group, average of 9 weeks wait. And the study looked at family well-being, as well as the symptomatic or relational manifestations of BPD. And there was a decrease in self-harm and suicidal threats, decreased physical fights, decreased explosive or aggressive verbal arguments, and decreased uncontrolled emotional outbursts, and also decreased withdrawal or refusal to interact. I want to observe this. This is the person with BPD. When family members were using the principles of MBT, their family members withdrew less or refused to interact, which I just think is a really fascinating, important finding. So compared to the delayed intervention group, the immediate intervention group reported a statistically significant decrease in adverse incidents between themselves and the person with BPD. That said, both groups, regardless of wait time, showed improvements in family members' depression, anxiety, and overall burden of the person with BPD's illness. And but the immediate intervention group had displayed better functioning in the family, empowerment, and sense of well-being. So just thinking about this in terms of some of the therapeutic techniques for patients, as Brandon was talking about, since MBT works to stimulate patients' reflections about mental states, MBT doesn't tend to prescribe cognitive or behavioral skills to address patients' challenges. Instead, what we try to do is practice reflection about mental states in the moments of emotional and interpersonal disruptions. That's this idea of reflect rather than reflex. So therapists work with patients to write out a written formulation tailored to patients' unique difficulties, which there's a lot to that, but the main idea, this itemizes patients' problems and mentalizing. So skip over this for the sake of time. So the idea is patients work to anticipate these problems. It could be reactivity. It could be desire to self-injure. It could be feeling triggered by a certain type of interaction or feeling rejected. And the whole idea is helping patients to press pause when they encounter them, to almost get ahead of it. I know this might be coming, so I'm going to try to press pause. What do they do instead? Mentalize. It's in some ways, it's almost always the answer in MBT. Mentalize. And that's the idea, is that sort of patients are going to try to reflect on mental states when they get stuck. And really what that means is, it's called the inquisitive stance. In some ways we go, what's mentalizing versus non-mentalizing? So one way to describe it, it's the difference between asking a question versus making a statement. And a lot of times what we're hearing from folks with BPD and other severe personality disorders is statement making. MBT wants folks to start asking questions, because the question is the buffer to impulsivity. So, some examples of we have mentalizing prompts, which are things that we do with patients to try to kind of help them know what to practice outside of sessions. So mentalizing yourself could be looking at the past. In that past situation, what was I feeling and wanting? How was I feeling about myself? What's coming up for me now? You can also, in the therapeutic relationship, what's coming up for me? Do I notice emotions, wishes, feelings toward the therapist? So we're trying to help folks actually not just sort of figure these things out, but to actually feel these feelings, but also to mentalize other people, to ask yourself and to help patients ask themselves, what is this other person feeling or wanting? What could be going on for them? Also, not just what, but how might this actually be quite valid for them, the other person, to experience things in the way that they are? And then trying to care, not just reading other people, but actually sort of cultivating a sense of care about that which is read. And also, we're going to encourage patients to do this in the therapeutic relationship itself. Mentalize your therapist. So rather than a lot of patients can sort of get into, there can be power struggles, there could be arguments with therapists. And in MBT, we're going to really, really want to get ahead at that and encourage patients to really ask themselves, what resonates for me about what my therapist is saying? What doesn't ring true? We don't want patients to agree with us, but we do want them to truly try to take in our minds. And the idea is, if they can practice that in the moment, they're going to be better equipped to do that in their relationships with their family members, loved ones, significant others. So there's a lot of the sort of other parts of this, but really trying to put yourself in the other person's shoes. So, so resources, I'm just going to throw this out there really quick, some kind of key resources. Great introductory text that just came out, the Cambridge Guide to MBT, written in a very user-friendly way. It's more for clinicians, but if there's one sort of book that is great for sort of the layperson as well, it's this book here. Brandon and I's book with Anthony is MBT for Pathological Narcissism. For those of you who happen to be interested in that topic or have family members with some narcissistic traits, you can check that one out. Again, it's more for clinicians. Check out the Anna Freud Center in London, which is the worldwide home of MBT. There's tons of resources there. Here, the Gunderson Personality Disorders Institute at McLean, we're offering lots of trainings. MBT Boston, we have online supervision groups and also a therapist directory, kind of helping folks find MBT therapists that we've trained with expertise in treating patients diagnosed with BPD. And I'm ashamed that I didn't think to put this on here, but Brandon, I was thinking there's the MBT Canada, right? We should have put this on there. I wasn't even thinking about that, but Karen Enzink runs like an MBT Canada organization. Karen is wonderful and she really knows her stuff. She's a world MBT trainer. And so check them out as well. They're really, really wonderful. So that's just some resources to get everybody started.
Wonderful. Thank you both so very much. I've been scribbling notes like crazy here, and there have been lots of questions come in already, and I know there will be more. So just so that our audience is aware, we do have several hundred people in the audience today, so I'm sure we will not be able to address all of the questions, but please post them in the Q&A or the chat, and we'll do the best that we can. I'm going to start first with a question about the logistical nature of MBT. So people are asking, is it done always individually? Is there a group component? Can it be done online? Is that effective?
Yes, the answer is yes to all of that. The original model, as it was first empirically shown to be effective, was actually a day hospital program in London that combined individual and group mentalizing treatment components. But since then, MBT has been shown to be effective as a pure outpatient modality. And actually, just like in DBT, which people might be more familiar with, what's called the dismantling study and studies, where people are trying to kind of pare down these treatments that were originally shown to be effective with lots of moving parts in them. People are trying to separate out, what are the kind of most active ingredients. So there are studies that are suggesting that standalone MBT groups, if someone's not able to access an individual MBT therapist, but can get into a virtually run remote mentalizing group. We have many of these at McLean, but unfortunately we're sort of bound to treating people who live in the state of Massachusetts. But there are increasingly this proliferating remotely accessible mentalizing groups, actually. We have many colleagues that are doing these and offering these around North America. And I know there are some in Canada as well that are doing this. So, the evidence is accumulating, but there's enough to suggest that these components of mentalizing interventions may in themselves be, transformative for at least some people. So there's lots of ways we can break it down, and we need more evidence about just what components are best for whom.
And another question is coming up frequently, which is it effective for special populations? For example, people who may have an intellectual disability or who are on the autism spectrum.
Well, it's a good question. What I'll say from a research perspective, there's no like sort of evidence supporting that. The only sort of there's from a in terms of the significant research, it shows that MBT is effective. Tons of research showing it's effective for folks with BPD. Good research showing that it's helpful for adolescents who self-injure, so essentially who might have emerging BPD, and then folks with antisocial personality disorder. That's what we can definitively say there's research showing efficacy, but we do definitely treat lots of folks who are on the spectrum, who have autism. I mean, I didn't get into this and when I was talking about the history of MBT, but the notion of mentalizing comes out of autism research and the idea of theory of mind. It was really Peter taking that idea of theory of mind and applying it to understand BPD. So I personally, in my practice, I find that they fit really well together and sort of working to kind of use some of these principles to help patients with sort of somewhere on the spectrum, sort of consider other people's experiences, be more in touch with their emotions, understand their emotions. I think they go hand in hand. But Brandon, anything else you would add about that?
I totally agree. And, there's just a couple of studies, not enough, as Bob says, not enough to draw grand conclusions, but there's a little bit of evidence that's starting to accumulate that perhaps maybe there was this older idea that MBT might not be so helpful for people on the autism spectrum because those challenges around theory of mind actually may be a little less context dependent than they are in BPD. But actually, there is some evidence that an approach that very carefully attunes to the particular theory of mind that someone with ASD may have actually may not be any less effective. And it may be better than some other things that are out there, but we do need a lot more evidence on it. Anecdotally, Bob and I and our colleagues often do see that MBT seems to actually help us tailor other BPD treatments a little better to the needs of those on the autistic spectrum.
Well, that's perfect. Thank you for that last phrase, because this idea about tailoring treatment and incorporating mentalization with other treatments. Of course, one of the questions from our audience is about the relationship between DBT and MBT. And Bob, you started to address that, but a couple of things. Are there pros and cons? Are there comparative results in terms of one thing being better? I know there's more research for DBT because it's simply been around a bit longer, right? And do the treatments complement each other, or is it kind of one or the other and you have to choose between them? Or would it work, where DBT hasn't worked? Is MBT something you want to look for?
These are always these are great questions.
They're the questions, right?
We definitely, and Bob, you should comment on this too. But we're sort of have this like embarrassment of riches at McLean Hospital, where there are options for people to receive MBT or BP or DBT or some combination of both, or there are TFP therapists around. But that tends to be fairly rare out in the world. It's also the place where John Gunderson, developed this more pared down, more basic approach to treating BPD. Good psychiatric management. With obviously Paul Links, right there in Toronto, and a lot of Shelley McMain. So I think the short answer here is that there's no grand conclusions about when is DBT going to be a better fit for someone, when is MBT going to be a better fit. There are some studies starting to compare the two. I would say that they're small enough, and a lot of the conclusions are not sort of statistically significant enough to draw population-based conclusions. But here's what people are interested in. I think clinically, what we tend to see is that often some people who have had attempts at DBT in the past, whether high quality or low quality, DBT, or maybe they didn't get very far with it for various reasons. But oftentimes, people develop a sense of mistrust toward a particular system or a particular treatment approach, where somebody might say, I can't sit in a room where someone has a whiteboard and they're trying to teach me skills. Anybody could learn these skills. And of course, that's not true. I mean, learning to do DBT well is quite complex and challenging for any of us. But people kind of develop these mistrusting channels in certain treatment modalities and systems. So sometimes the particular appeal that MBT can have for somebody who's written off DBT can help actually kind of generate a trust and an engagement in this alternate way of approaching treatment. So some people kind of really take to the notion that we're not actually trying to sort of coach particular skills, but we're actually trying to just learn to be more uncertain. And some people like the kind of the focus on emotions and the way that we try to get to that as a group, and the kind of mentalizing laboratory, and the more open-ended exploration that happens in MBT groups. It's very different an MBT group than a DBT group, where the point is to really kind of infuse the skills training. MBT groups are quite exploratory, actually, from the top to the bottom. And people are bringing in experiences from their past week. And what they have to do is actually try to present these difficulties. And the group has to respond, and everybody has to actually try to work to mentalize these painful experiences. So that's quite different than sitting in an DBT skills group. Both are helpful, but which is helpful for whom is something we're very much still trying to figure out as a field. Bob?
Yeah, I completely agree. I would just throw out there anecdotally, and this is partly what led us to develop MBT for narcissism, is some folks who with BPD with more narcissistic traits can report feeling very patronized by DBT. They feel talked down to. They don't want to be in the student role. And so one way in which, if you ever have somebody who's like really like, I can't deal with that, and I say MBT has a leg up because we intentionally are working to be at the same level as patients, like sitting alongside them, which tends to feel less offensive to folks at times. So if you find, if you know people in your life who tend to have a response like that to DBT, maybe worth like sort of giving MBT a shot.
Right. Thank you. Maybe you could just expand a little bit on this and speak about mindfulness and whether mindfulness has a role in MBT, or is it, that idea of pausing, kind of slowing things down and reflecting? Is that partly a mindfulness activity that people are engaging in, or is that just applying one framework where it doesn't really apply here?
I'm an answer, but I really don't have any ground to answer because I have not really been trained in DBT the way that Brandon has, but I'll just sort of throw it out there and see what Brandon has to say about it. I like to think about, DBT has mindfulness of current emotion. And that really, like, in some ways, we could think about sort of like mindfulness involves so many things. It's sort of attending to the present moment, what's going on around me, what's going on in my body. Like mentalizing could even be seen as like a species of mindfulness. It's like specifically mindfulness about mental states, and so I think that in some ways that's sort of like think about it's kind of like focusing it, and the parts of DBT that are really attending to putting words on feelings, representing feelings, sort of experiencing feelings, that part I think has significant overlap with our construct of mentalizing. Brandon, I don't know if you would agree with that, that response, if it fits at all to a well-trained DBT person like yourself.
No, I love it. I would only add that, DBT can tend to sort of formally define mindfulness as being about, pure observation. The mindfulness how skills, or the what and the how skills, right? So pure observation, right? Sort of distinguishing what is a judgment versus what is kind of more objective observation. And so we can't, in a way, we can't at all directly observe mental states. What we can be mindful to in a formal sense is, someone's behavior. I can practice separating out my judgments from my observations. And so there's an overlap here, but MBT is going to actually really focus on okay, you have these observations of how someone's physically responding, and you have these kind of inferences, these imaginative guesses, these conclusions that you draw, however you're getting there, these impressions that you have about what's going on in your own mind and others. And I think MBT is trying to work sort of in that murkiness about how do we hold all of that together? How do we appraise and then act on those appraisals based on the sort of multiple streams by which we kind of come to think we know something about ourselves and others. So there is overlap, I'm trying to say, but they're not the same thing, mindfulness and mentalizing.
Wonderful, thank you. Because these questions are so interesting, and it's interesting that different people came up with the same question, right? So it's obviously something that was in a lot of people's minds. I would like to turn to the family piece. And just ask you to speak to that a little bit with the few minutes we have left. I wonder, for families who are listening, and of course, it's not easy necessarily to access this treatment, as it's not, easy to access any kind of treatment. But if families wanted to embrace this for themselves, would a family member be, would it be effective for them to kind of learn some of these techniques themselves, to model them, to bring them into the relationship? Would they be more likely to be effective if they were to, say, get one of the clinical books and learn how to, do MBT to their loved one, which I think is also sort of a really, we might want to do that. We might be tempted to do that. Would that be effective? What would be the most effective way for people to embrace this, to bring help to their families?
Is such a good question. And this is a real deficit in the literature, which is actually like sort of, I don't know, spelling out the principles of MBT sort of like in everyday kind of like life. So I think that's a project that sort of we're going to be working on kind of coming up, and like how do we actually kind of operationalize this for like use in sort of family systems or patients using it to sort of help themselves. What we have in the meantime is exactly that, like books written for clinicians. Unfortunately, I would recommend Ozen and Peter Fonagy have written Mentalization-Based Treatment for Families. That's a really, really good book. There is a book that just came out last year, 2023. I don't remember the name of it, but it's basically mentalization-based treatment for parents, actually. And it was one of the, Elliot Juris is one of the authors if people want to look it up. Yeah, okay, that's good. And And so in terms of those, but I wouldn't really recommend personally, quote, doing MBT on family members, just for boundary purposes and stuff like that. That said, the core techniques that unfortunately we didn't get to spend much time on, but the importance of empathic validation, trying to ask questions about people's feelings, holding the not knowing stance. So, it can get easy when we're working with folks with BPD and other personality disorders to get more knowing, to take refuge in, I know that what's happening here is problematic. The problem is that often exacerbates interpersonal conflict. So holding the not knowing stance, being curious in your interaction with the family member rather than taking an authoritative stance. If I had to, guess about what makes the sort of MBT FACS program effective, I would probably attribute it to kind of bringing those principles into the family system. Brandon?
Just briefly, I would say, something we might often say to families or partners or loved ones is, just, let's say that, you feel like your loved one is very certain about things, or they're always declaring this or that. They're very sure about what's going on, and they're kind of you feel they're getting you wrong, or they're getting people wrong on a regular basis, or there's so much black and white thinking. You can just practice that little piece of mentalizing that Bob's talking about, just being not knowing yourself, being curious. And so every time you think you're hearing certainty or too much rigidity about something from your loved one, you just try meeting that with something that's not knowing in yourself. Just try asking questions. It sounds so basic, and you don't want to, just kind of be parroting, therapist, techniques. But if we can do it genuinely, what we think is part of the kind of transformative mechanism in MBT is giving a loved one an experience of someone who cares, trying to put in the effort to find out about their mind, find out about their experience, because that's going to go imperfectly every time. There's, there's no perfect validation. There's no perfect mirroring that really happens in human relationships, at least. So this sense of, just trying to give someone the experience that I'm trying here. The way I'm trying is by asking you questions. And I'm going to follow up on how you answer that question with another question. So just, I think that showing that interested, not knowing, inquisitive stance, that is something family members can do, in addition to all the other times where families do need to actually sometimes just take a more rigid and concrete stance. No, this is not okay in my house. This is a hard stop for me. But what's that like for you? Then you hop over to a question and not knowing, gosh, what's this going to be like that I'm taking such a firm stance? No, you can't do that in this house and expect to stay here. It's not okay with me, but what is that like for you? Kind of when I have that strong stance. So you can keep bouncing it back to uncertainty and not knowing. I think that's good for us all to be doing around BPD.
Great, thank you. And I'm seeing a couple comments come in or questions, where family members are saying, how do I deal with someone who is, maybe gaslighting me, they're lying to me, right? And so, to me, it sounds as if these are situations where you really could bring that sort of openness and curiosity to that interaction. And yet, as a family member, we're dealing with our own emotions, right? Which are then arising, and that makes it more difficult for us to be mentalizing in that moment too, right?
Definitely. And I think that's what was useful, but Brandon kind of emphasizing this importance of boundaries. So one of the sayings that we have at MBT about optimal therapeutic dynamics is, it's not really a saying, it's more of just a phrase, two minds in the room. And the idea is that if it's too much the therapist's mind kind of taking up the space, that's not helpful to the patient. That's not helpful to the patient because the patient won't feel seen. Or if it's too much of the patient's mind and the therapist, it just kind of completely loses a sense of self in relation to them. That's also not helpful for patients. And so I would think that something similar could be said about family members and family systems. Like, it's not just all pure empathy, because if you get collapsed, you'll get lost. And that's not good for folks with personality disorders of BPD. At the same time, you know, we've got to balance that with sort of really regarding the other's experience. So how can we kind of have both minds in the room in the family system?
Great, thank you. I think that's a great place to leave it. Thank you both again so much. I know a couple of those book titles have just been posted into the chat. So people who were interested in the books for further research and reading, please take a look at the chat before we end the webinar, and you can click on those links to see the books that were recommended. I want to remind you all again that Sashbear is a registered charity, and we welcome donations so that we can help provide this type of resource to you on an ongoing basis. And once again, I want to thank our guests this evening, Brandon, Unruh, and Bob Drozek. Thank you so very much for being with us.